Hello, everyone. Welcome back. As usual, we're going to start with a question. A 54-year-old woman has a pulmonary embolism but does not develop pulmonary infarction. Which of the following features of the lung explains this finding? So the best answer there will be dual blood supply. Let's see why. So in today's lecture, the goal of today's lecture is to cover ischemia and infarction. And then under ischemia, we're going to talk about definition of ischemia, the clinical outcomes of ischemia, and causes of ischemia. And under infarction, we're going to talk about definition, factors affecting likelihood of infarction, and types of infarction. And guys, these are high yield for the exam, so we have to make sure we know this. So let's talk about them. So starting with ischemia. So ischemia by definition is a reduction or complete loss of blood flow to a tissue or organ. And when we look at the consequences of ischemia, the how bad it is depends on the severity and duration of reduced perfusion. So what are the clinical outcomes of this ischemia? So ischemia could lead to tissue or organ atrophy. Remember, we spoke about atrophy in the past, which is a form of cellular adaptation, right? And this atrophy normally occurs in a chronic setting. So for instance, if somebody have underlying atherosclerosis, and over time that gradually reduce the lumen of the blood vessel, thereby leading to gradual reduction to the tissue. And the way the tissue or the organ is going to respond to that is by atrophy. And that's why, for instance, if you have a 65-year-old man with uncontrolled hypertension, history of diabetes, hyperlipidemia, and now did a ultrasound of the kidney, and the one kidney is smaller than the other one. And if you are asked, what do you think is happening to that small kidney? Likely that patient probably have renal artery stenosis, whereby leading to what? Atrophy, right, of that kidney. Very good. Secondly, it can lead to organ dysfunction, which could impair physiological activity, because if they are not getting enough blood supply, that means there's going to be hypoxia, and that could affect the function of those organs. And don't forget to watch the video on hypoxic cellular injury. Very detailed. Is going to help you. Also, the last one there is infarction, which is localized tissue necrosis from prolonged ischemia, which we are going to talk about in a second. So let's look at the causes of ischemia. So as we know, right, so the blood is going to move from the artery, right? So from the artery, it's going to go to the arterioles, right? And then from the arterioles, then it's going to go to the capillary, right? You want to go to the capillary. And at the capillary, that's when the gaseous exchange takes place, right? So oxygen is going to go to the tissue, right? And then what's going to come in exchange for oxygen? Your carbon dioxide, your CO2. And then those deoxygenated blood now will be taken to the what? Venous. And then from there, they're going to go to the vein. And then from there, they're going to return back to the heart, and they're going to go to the lung for oxygenation. So when you look at the causes of ischemia, it could be a problem with the arterial side. So if there's a decreased arterial blood flow, so if there's not enough blood flow through the arterial side. So this could be due to thrombosis, right? So thrombosis is when you have formation of blood clots at a particular site, right? And that blood clot leads to occlusion of the blood vessel. And this could also happen in the setting of advanced atherosclerosis, as we're going to see later, whereby you form atheroma, and that atheroma blocks the blood vessel. It could also be embolism. So embolism is when you form a clot at some point at a particular location, and a part of that clot, blood clot, or the whole blood clot itself migrates and move to a distant location, right? A distant location, and that will lead to occlusion. So clot travel from a proximal site and lodges distally. So that would be embolism. So any of these could lead to decreased arterial blood flow. The next one is decreased venous drainage. So if there's a blockage on the venous side and it can't drain the blood, right? So that means the blood from the arterial side will not be able to come into the capillary to participate in gaseous, to allow oxygen to be released to the tissue. So when the blood cannot drain from a tissue, pressure rises and arterial inflow collapses. And a big example of this is phlegmasia, cerulean, dolens, and this is severe DVT causing venous blockage and ischemia. As you know, the treatment for deep venous thrombosis is what? Anticoagulation. But if somebody is developing leg ischemia as a result of DVT, then that could be an indication for what? Thrombolytic, right? So they might need a thrombolytic or they might need a mechanical thrombectomy whereby you have to remove the blood clots. Moving on, guys, and the last cause under here could be shock. So remember, shock is generalized hypoperfusion. So, and this could be hypovolemic shock, maybe cardiogenic shock, obstructive shock, or distributive shock, right? And under distributive shock, this could be septic, maybe due to infection, or non-septic. And the guys, very soon we're going to be talking about in details about shock. And make sure you subscribe so that by the time that video is out, you're going to be the #1 person to see those videos on shock. So moving on, guys. So now we're done with ischemia. So let's talk about infarction. So by definition, what's infarction? Infarction is irreversible cell death or necrosis caused by prolonged ischemia from vascular occlusion. And remember what we discussed under necrosis in the previous lecture. We said anytime you have loss of blood supply or ischemia to any particular tissue or organ in the body, classically you're going to get what? Coagulative necrosis. But the only exception is in the brain, and what we see in the brain is going to be what? Liquefative necrosis. And guys, if you've not watched those videos on necrosis, please do watch those videos. It's going to help you. So moving on, what are the factors affecting the likelihood of infarction? So in other words, if there's ischemia to a particular tissue or organ, what are the factors that will most likely predict that this tissue may develop infarction? Because it's one thing to have ischemia, it's another thing to develop what? Infarction, which is cell death. So let's look at them. So one is the size and the number of occluded vessels. So if you have a very large vessel or multiple vessels that have been blocked, then that increases the risk of ischemia or leading to infarction. A classic example is SADU pulmonary embolus, whereby somebody had a big pulmonary embolism and which could lead to sudden death, right? Because with big pulmonary embolism, that will suddenly increases the right-sided afterload, and that could make the cardiac output to be equal to 0, and that patient could die. And then the next one is collateral circulation or dual blood supply, which is what we saw in the question earlier. So the more collateral flow, the lower chance of infarction, because even though if one is blocked, they will still be getting blood from other collateral circulation or other blood supply. And so high infarct risk organs with end arteries, right? So example like kidney, spleen, they only have one artery, right? So only one artery. And because of that, these tissues are more prone to what? Infarction. Lower infarct risk, those are organs with dual blood supply, like we mentioned in the case of lungs. So with lungs, we have the pulmonary and the bronchial arteries. As opposed to the liver, we have the hepatic artery and the portal vein. So that's why the lung, the liver, they are less prone to infarction, as opposed to the kidney and the spleen, whereby they have the end artery or single artery, they are more prone to infarction. Very good. Moving on to the next factor is oxygen demand of the tissue. So if the tissue has a very high oxygen demand, that increases the likelihood of infarction to occur. And this tissue includes the heart, and the brain, right? Remember, the heart is constantly pumping and the brain is constantly working, right? And the next one is pre-existing tissue damage. So if somebody already have a tissue that is already been damaged, they may not be able to tolerate ischemia very well, and that could lead to what? Infarction. A classic example is a patient who have chronic obstructive pulmonary disease like emphysema, or a patient who have interstitial lung disease that now develop pulmonary embolism, then that could lead to what? Ischemia and infarction, because those tissues are already been affected, damaged, or diseased, and they may not be able to tolerate ischemia very well, and that could lead to infarction. Guys, this is IE topic today. So moving on to types of infarct. So there are two major types of infarct. We have the pale infarct, which is also called white because it looks white on gross. And we also have hemorrhagic infarct, which is red infarct. Why do we call it red infarct? Because it looks red on gross. And this pale infarct occurs in solid organ with single arterial supply. Example that we mentioned earlier, the heart, the kidney, and now we're adding spleen. And so that's number one. So they have a single arterial supply. And the second reason why this occur in them is because they are dense tissue. And because they are very dense tissue, that limits the red blood cell diffusing or moving to that area after infarction has occurred. So mechanism, lack of blood inflow leads to necrosis, remains pale due to minimal hemorrhage, right? And as we can see in this gross picture, you can see that wedge shape infarction there, right? And then you can see it looks pale. So that's an example of pale infarct in this kidney. Moving on to hemorrhagic or red infarct. So hemorrhagic, like we mentioned, is also called red infarct. So this occurs in loose textured tissue. Example of those tissue includes the lungs, the intestine, and the testes, right? And when you look at this tissue, they have multiple blood supply. That's number one. So dual or collateral, that's one reason. And then the other reason is that when you look at the tissue, they are very loose. So they have loose textures. So because they have loose textures, that also predispose them to hemorrhagic infarct in the setting of ischemia. So these are areas where blood flows returns after occlusion and reperfusion injury, right? And the mechanism, the red blood cell leak into necrotic tissue and leads to what? Red coloration. So if you have one branch that is being blocked, right, then blood can still come from the other one, thereby leading to hemorrhagic infarction. And the next one there is free radicals from reperfusion injury. And guys, if you've not watched the video on free radical cellular injury, I encourage you to watch that video. It's going to help you. And who can remind us which enzyme is involved in this free radical injury, in reperfusion injury? Very good, very good. Xanthine oxidase, right? And this xanthine oxidase is going to help to release what? Superoxide, right? Free radicals. And this superoxide free radical is what's going to do the injury. And as you can see in this picture of the lung, you can see that infarction in that area, and you can see the way it looks red. So that's a classic example of hemorrhagic infarction. So we've come to the end of today's video. So let's do some questions together. So the first question there, a 67-year-old man with long-standing hypertension, hyperlipidemia, develops sudden onset of chest pain radiating to the left arm. So history of coronary artery disease, so he has hypertension, hypertension and hyperlipidemia. And now he's having sudden chest pain radiating to the left shoulder. So that's concerning for cardiac ischemia, right? EKG shows ST elevation in the anterior lead, right? So if you see ST elevation in the anterior lead, you worry about what? LAD occlusion. Which of the following best describe this type of necrosis that will occur in this affected tissue? So based on our explanation, the best answer there will be what? Coagulative necrosis. And if this is supposed to be in the brain, then it's going to be liquefied necrosis. Very good. Next question. A 32-year-old man develops severe left leg swelling and cyanosis. Ultrasound reveals extensive iliofemoral deep vein thrombosis. So that's a big clot there, guys. And it progresses to tissue ischemia of the leg. What mechanism explains the ischemia in these conditions? What we said? Very good. Venous occlusion causing impaired arterial inflow. Check it out. Next question. A patient with atrial fibrillation abruptly develops severe left flank pain. So what's the relationship between atrial fibrillation and left flank pain? As you know, with atrial fibrillation, right, these patients have high risk for forming thrombus in the left atrium, right? So in the left atrium, they could form blood clots there, right? Because of the stasis of blood. And those blood clots could move from the left atrium into the left ventricle, and from the left ventricle, they could move into the systemic circulation. And depending on which direction they go, if they go up, they're going to go to the brain and they could cause what? Stroke. And if they come down, they could go to the spleen, causing infarction. They could go to the intestine, causing infarction. They could go to the kidney. They could even go to the lower extremity, to the leg, thereby causing ischemia and infarction. So the CT scan reveals a well-shaped area of necrosis in the left kidney. Which of the following underlying features of the kidney explain why this infarct is pale? Remember, we said it's because of what? Very good. And artery circulation. And the last question, a 70-year-old man undergoes coronary angioplasty for occluded LAD. Several hours later, so hours later after we have done the coronary angioplasty, so meaning that we have opened up the obstruction, he later developed arrhythmia and a worsening chest pain, right? So somebody that already undergo corona, who had the occluded LAD, we've opened up the obstruction, but now this patient start having arrhythmia and worsening chest pain. And it will check some cardiac biomarker, example like troponin, right? Our CKMB, right? And they will realize that this enzyme, they are on the rise, even higher than when the patient first came in. So which of the following best explains the tissue damage occurring after reperfusion? So this patient probably undergoing reperfusion injury. After you open up the blood clot, after you relieve the obstruction, then the xanthine oxidase start producing a lot of superoxide free radicals from the oxygen that is coming in. And so the best answer here will be very good. Free radical mediated cell membrane damage. Don't forget to watch that video on free radical. You're going to understand all these grammars that I'm speaking. We've come to the end of today's lecture, guys. Please don't forget to subscribe, share this video, like this video, and I will see you in the next lecture. Bye for now.